Welcome. I'm describing two different techniques of robotic cosmetic cholecystectomy done in young girls. I call this a cosmetic cholecystectomy because all the ports and the suture lines are hidden in the skin lines and they are all below the umbilicus with intraumbilical camera and the working ports along the skin lines near the anterior superior iliac spine on either side, and an assistant port in the suprapubic region which is also hidden, and that's why most of the scars are hidden with this technique of a cholecystectomy. So the first technique we are describing, this was a young 24-year-old lady who had just passed his MBBS, and she had cholelithiasis, stone of 11 mm, and these are the port placements with which we went in. You can see here that it gives a very good view of the Calot's triangle or the gallbladder and the area of the duct and the cystic duct. So we start incising the peritoneum after seeing and visualizing the rubeus sulcus, and first we start with the posterior dissection. The first technique, we are using a bipolar Maryland forceps for the dissection. You can see here that it can create a plane. Not only that, it can do buzzing as well as it can do cutting. So all the three functions can be done very well. Once the posterior dissection is done, we now come to the anterior dissection as we go up towards the gallbladder, body of the gallbladder, and dissect the peritoneum between the liver bed and the gallbladder. Next is the step to create a posterior window. A large posterior window is created before which we never approach the cystic artery or the Calot's triangle. So once the posterior dissection is done, we approach the cystic artery. That is a critical view of safety where only the artery, the only structure that enters the gallbladder. That should be demonstrated by doing a careful dissection of the Calot's triangle, and then the artery is taken with the bipolar coagulation. We have been routinely using bipolar coagulation for the artery in all our laparoscopic techniques rather than using clips. And once this is done, then we dissect the cystic duct further, go down, make sure that there is nothing, no stones there, milking of the cystic duct is performed, and then we occlude the cystic duct with the use of Hem-o-lok clips, which we believe is much better than using the titanium clips. So we use 3 clips and divide the cystic duct in between. For cutting, you can use a tip of the bipolar Maryland with a micro mode cutting mode, which delivers the energy which can cut the structures or tissues. And this is also good technique so that you can avoid, with one instrument you can do many functions. The gallbladder is then gently separated with using the tip of the Maryland device, so it can help in not just buzzing but also dissecting and dividing the structures. The peritoneum and the gallbladder is separated, and it is always placed in the endo bag before removal from the abdomen. So this is the first technique where we have used and this was a post-operative 7 days image of the patient with scars quite well hidden inside the undergarments. The second technique is where we have used the scissor. This was a young girl, 10-year-old girl who had cholelithiasis, and he had a history of acute pancreatitis. So here also we use the 2 robotic ports low down, far away from in the lower abdomen, and with this we could have a very good vision of the gallbladder, neck, and the Hartmann's pouch. So here we start incising the peritoneum after seeing the rubeus sulcus and start with the posterior dissection. The 3D vision and the precision of the endowrist movements of the robotic instruments, they help us in helping us to do this dissection. And then we create more posterior dissection to go between the gallbladder and the cystic plate, and subsequently we start the anterior dissection, identify the lymph node, do the anterior dissection, make sure that we get a good dissection, and subsequently the cystic artery here is dissected away. The cystic artery is bipolar coagulated, looped, and the cystic duct divided in between the Hem-o-lok clips and then divided. There was some bleed from the gallbladder bed which was eventually controlled. The next is to divide the peritoneum from the posterior dissection, and then the anterior dissection was performed to divide the gallbladder, separate from the gallbladder bed the cystic plate and remove the gallbladder. There was a small bile leak during this dissection, and then we always use an endobag to place the gallbladder in the endobag to do a lavage and do a good saline wash of the gallbladder area, and subsequently then finally we close all the robotic ports, and that is the end of the procedure. Patient had an uneventful recovery. Thank you very much.